Good morning all to the Pathological Society and Jean Shanks Pathology Grand Rounds. My name is Professor Sarah Coupland. I'm the president of PathSoc, and it gives me great pleasure this morning to introduce our speaker, the third Grand Rounds lecturer today. And he's Professor van der Laak, who's a professor of computational pathology in Nijmegen in the Netherlands. He is a pioneer with computational pathology and the interpretation of digitized histopathological images using AI. He he instigated and coordinated the chameleon, tiger, and monkey grand challenges, and is involved very much in the various task forces in AI and computational pathology, for example, with the European Society of Pathology. I had the pleasure of listening to Professor van der Laak speaking at USCAP, where he gave the Nathan Kaufman keynote lecture, which really, I think, blew away the audience. It was really exciting. So with that, and without further ado, I'd like to hand the podium, inverted commas, over to Jeroen, and so that he can speak about computational pathology and its application in breast cancer. Thank you very much.
Thank you, Sarah, for the nice introduction. Let's see, I can share my screen like this. And of course, I would like to thank the PathSoc for inviting me for today's lecture. It's great to be able to show some of our work. I think we have questions at the end, so I'll skip that for the last 15 minutes. And I would like to show you a bit about the AI research that we do, mostly focused on breast cancer grading. I will show some other things as well, but mostly this is my main line of research, I would say. Maybe it's good to say that I'm not a pathologist. I have a computer science background. I have been in pathology for a long time, for 33 years, I think. Actually, I lost count by now. But I'm not a medical doctor, I'm not a pathologist. So if any small mistakes are here in the pathology domain, then please forgive me for that. And I have to show you my disclosures. So there are some companies I work with. Probably most notably is EOSIN, which is our own spin-off company. So it's a very small startup in the field of AI in pathology. And I will show some results of a study that we did with EOSIN for IVDR certification of one of our products. Okay, well, I don't have to explain anything about this. You know what a tissue section is, obviously. And for instance, one thing we studied a lot is what you can see here, a tissue section of a couple of cuts through lymph nodes of a patient with breast cancer. And as you know, a task for the pathologist here would be to find metastatic regions because that would give you a different end stage and could have consequences for the treatment of the patients. And also, as you know, of course, most part of the world still uses traditional microscopes to study these samples. I know in the Netherlands, for instance, we are actually quite far advanced. So the majority of the Dutch pathology labs is digitized, as you can see here. I know that if you go to the US, less than 10% of labs are digitized and 90% still use microscopes. And I think the UK has picked up quite rapidly in the last 5 years, I think with very large initiatives. I work together with Darren Trainer in Leeds and PIC initiative. So I think we see digitization of pathology coming, but it's not as fast as we would like it to be. And obviously, if you want to be able to build AI, to use AI, artificial intelligence techniques, you will need pixels and you need digital images. So it's very important for us to, if we want to bring AI to pathologists, that digitization takes place. And this is still, I think it's still a bit cumbersome. Now, the thing we want to, that we are developing and we are actually trying to also do in our own lab is we can scan the slide, as you can see here. So the thing in the top is a scanner. What we would like to do is we would actually have AI be present in the whole workflow. So basically what we are setting up now, and that's very doable, is before a case goes to a pathologist, the AI could already have processed that case, and the AI results could be there for a pathologist. Even if they open the case for the first time, they could have AI results to guide them. And maybe just as important, you could also think of AI actually being part of the workflow. So I'm not sure, it's just an example. If you have a breast biopsy, the AI could already decide for you whether there's a high likelihood of having cancer. And if there was a cancer, it could already order your ER/PR or HER2 stains for you. So you could also, let's say, optimize your workflow, and AI could be part of that. Now, one thing we studied a lot in the past, I will not go into a lot of details. Sarah already mentioned the chameleon challenges. And just as an example, how AI could be, say, a very simple aid for a pathologist. If we have these lymph nodes, and if we zoom in a bit, this is what it looks like. So this is a glass slide with cuts through a couple of lymph nodes. And your task is kind of tedious. You have to find metastasis. It's important, but we also know that it takes time, and it's not the most interesting task for pathologists probably. And also we know from studies that pathologists may overlook very small metastases because they can be very well hidden. So how cool would it be if you would have an algorithm that, if you open the slide for the first time, could do exactly this for you? So it could tell you, okay, this is a slide, you can just go over it, do whatever you want. But maybe you should start looking into these 3 regions that have been detected by the algorithm as being suspicious for metastatic tumor. And actually in this case, and this is a real case, it's not a fake one. In this case, you can already see that the algorithm was actually quite good. It picked up 3 small regions of 4 that are metastatic tumor. And the right one, I think, is actually quite remarkable because it's only a very small number of tumor cells, and still it was picked up by the AI. Now, we did in 2015, 2016, so it was published in 2016, 2017. We did a couple of studies which we called Chameleon, which is about cancer metastasis detection in lymph nodes. And what we did, and these are what we call grand challenges. So it's not the same thing as the grand challenge funding scheme that you have in the UK. In a grand challenge, what we do is it's kind of a competition that we set up. We have done a lot of these in radiology and also in pathology, where we define a problem. So in this case, the problem is find lymph node metastases. We collect data and we share data with participants in our challenge. And then we ask people to develop their algorithms, their AI, to solve our problem with our data. Then we ask the participant to upload their algorithm to us, and we can test the algorithm on a new set of cases that was not part of the training set. And we can decide which metrics we want to use to, say, assess the quality of the algorithms. So the great thing about a grand challenge is that people work on the exact same problem with the exact same data, and they are judged by the exact same metrics. And because of that, this kind of grand challenge is great for moving forward our field, because it means that it's different approaches to the problem, different solutions to the problem, can be compared very nicely and very fairly. So we did this challenge, and what we shared was a lot of lymph nodes with very detailed annotations of the tumor areas. And if we zoom in, this is what it looks like. And we used a lot of immunohistochemistry to make these annotations. You can imagine this is actually a lot of work. This was done by students mostly. And the good thing now, if you have these annotations, is you can train AI model, typically a neural network, convolutional neural network. And what you can do, for instance, is you can train the model by showing it a lot of small image regions that are benign, healthy lymph node. And you can show it small image regions that are metastatic tumor. And the way deep learning works, let's say the deep learning that we use today works, is you show it a lot of examples, and the deep learning the AI starts to learn how to solve the task automatically. You show it, say, 1,000, 10,000, 1 million of these small patches, and you label them with either, in this case, normal lymph node or tumor. And what happens is that your AI starts to pick up the characteristics that distinguish normal lymph node from tumor. So we shared a lot of these examples with the annotations, and we asked people to build their algorithms, send the algorithms to us. And these are just a couple of examples from this challenge from Comedian 16. So on the left, what you can see is this is the outline that we provided. This is what we expect the algorithm to output. And then you can see the three columns next to it. So one is Harvard Medical School and MIT. The other one is Harvard Medical School with MGH. And this is, I'm not sure, CEO Lab, maybe a commercial party. What you can see here is it showed the AI shows in orange what it thinks is tumor and in purple what it thinks is benign. And you can see already here that it's actually extremely sensitive in picking up the tumor. It really learned what tumor, what metastasis looks like in this context. Now, we did a study, and I will not go into all the details. It's also a bit old news. This was already published in 2017. We did a study in which we showed that this is a set of 130 slides. And we asked the algorithms to give us a slide level label whether the slide was positive or negative. So the algorithm processes the slide, sees if it finds any tumorous regions, and if it finds tumorous regions, then it will say the slide is positive, otherwise it says the slide is negative. And in this case, we had 130 slides, of which, from the top of my head, I think some 40 had metastases. And metastases ranged from micro to macro metastasis. We didn't really have isolated tumor cells because that's really tricky also for the human, so we decided not to include that. And what we did was, next to having the algorithms process the slides, we also asked one pathologist to begin with to go over all these slides and give them a label as positive or negative. And we asked the pathologist to just take as much time as she needed to do this task. And this pathologist is shown in this graph as the green diamond. And this graph is what we call an ROC curve. And if you're not familiar with ROC curves, it shows on the y-axis the sensitivity. So which part of the positives was picked up by, in this case, the pathologist. And you can see the pathologist picked up 95% of the positives. On the y-axis, what you can see is 1 minus specificity, which means how many of these, of the negative ones, are classified as negative by the algorithm. And in this case, and for some reason, in ROC curves, you always reverse this. So it's a 1 minus specificity. So in this case, you can see that this pathologist has a specificity of 100%. It means if there was no cancer, she would never label them incorrectly as being cancerous. Now, you might wonder, if a pathologist has all the time in the world, why does she not have 100% sensitivity? Well, just to show you, this is one of the positive cases, and this is a very, very tricky one. This was confirmed by immunohistochemistry, so we know the annotations are correct. But you can imagine, even if you have a lot of time, this is very tricky. Now, in our study, what we did next, we gave the same cases to 15 more pathologists. But in this case, we gave them a time limitation. We gave them 1 minute per slide. And the orange circles are the pathologists which have limited time. Now, what you can see is that their specificity remains extremely high. So they don't see tumor if there's no tumor, but their sensitivity drops to 70, 60, even 50% for some of them, which means that because they have a limited time, their accuracy goes down, which is not a surprise. The sensitivity goes down, which is not surprising because small metastases will be overlooked if you have limited time. Now, the good news in this graph is the lines are the algorithms from our challenge. And why are there lines? There are lines because an algorithm has, let's say, a parameter that you can tune. And you can say, okay, I want the algorithm to be very sensitive. The price you pay for making it very sensitive is that the algorithm will also start to pick up false positives. You can also say, I want the algorithm to be very specific, but then you have high specificity, but then you might miss small metastases. So the algorithm can be tuned. And the good news here is that the best algorithms are as good as a pathologist without any time limitation, which is not surprising because the algorithm is capable, and has the luxury, to go over the entire image at the highest magnification. So the algorithm can really look at every tiny field at the highest magnification, and so is very sensitive for picking up metastases. So I think the good news of this graph is, if you would give a pathologist with limited time in your daily day-to-day practice, would give this algorithm, you probably would go to a diagnostic quality which is as good as if you would not have any time limitation. So it would make you very efficient and at the same time very accurate. Now, this is a study from people at Google. Google also studied this problem. And actually they found that if they give this algorithm to pathologists, and it's still quite a limited study of 70 cases and 6 pathologists. If they give the algorithm to pathologists, they found that diagnostic accuracy goes up, and there is a time gain of, I think, 25 to 30%. So this is exactly as I told you in the last slide, that there is a great opportunity here because it can help you to be more efficient and it can help you to be more accurate. And still the control, of course, is completely with the pathologist. Now, as is shown in my title, I would not like to go too much into lymph node metastases. I would like to show you what we do in, say, in the realm of breast cancer grading. And I guess if you're in pathology, you probably know everything about grading. And just to show you, grading is not a new concept, as you are probably very much aware of. And actually, this is a nice publication from exactly 100 years ago, which describes grading as pretty much the same fashion as we do it today. So it describes that we can do grading having 3 different components that say assess different characteristics of a tumor, breast tumor. And these 3 characteristics together give you a very good overview of the aggressivity of the tumor. And in this paper, for instance, from 1997, it was mentioned again, the grading, also the way we do it today, correlates well with survival. This is one of the very early papers of the people in Nottingham that studied a lot the grading, in which they show that grade is strongly prognostic. And I guess also for you as pathologists, I don't have to go into a lot of detail. Grading consists of 3 components. So we look at the architecture of the tumor. Do we see very tubular appearance or is it a very solid appearance? And then the pathologist scores this as the amount, the extent of tubules in your tumor. If it's more than 75%, so it's predominantly tubular, we would give it a score 1. If it's less than 10%, so it's a very solid tumor, we give it a score 3, and otherwise it's score 2. A similar thing happens for the cell nuclei, the tumor nuclei. So if nuclei look very much still like normal ducts, then we would give it a score 1 for nuclear polymorphism. If they are very abnormal, we would score the 3, and otherwise it's a score 2. And we count mitosis, so proliferating cells. Now, these 3 scores are added, and then there is a table that translates this into a grade 1, 2, or 3 for breast cancer. Now, this system was, I think the system we use today was developed probably 40, 50 years ago, and we still use it today for every new breast cancer case. I think there is a lot of promise. I think this makes a lot of sense. Looking at these different components, these different characteristics, and combining them into one score. But I think also there are some challenges, and I hope to convince you that AI could actually be a great help in overcoming the challenges. Now, the biggest, or maybe not the biggest, but one of the challenges is one that is very much present in a lot of grading things we do in pathology. We know that, for instance, if we look at nuclear polymorphism and we score this also in digital images, it is prognostic. Even that one factor, not just anti-target grade, but also this one factor is prognostic. But we also know that if we have different people score nuclear polymorphism, we know that consistency between pathologists is not perfect. So if we ask the same, say, scoring from 5 pathologists, they will not all give you the exact same scoring. And that is very nicely displayed here in the kappa statistics in this table. You can see that in this study, for the different components, the kappa score is between 0.56 and 0.64. And if you're not familiar with kappa, kappa is a statistic that ranges from 0 to 1. If 2 people perform the same task and they are completely they are completely independent of each other, and the score has no relationship, then it's a 0. So it's pretty much throwing a dice. If they score the exact same for every case, it will be a 1. So you can imagine a kappa of 0.6 is okay, but it will have consequences for the outcome and maybe also consequences even for the treatment advice we give to patients. And therefore, in this study, they conclude systematic differences between pathologists, in this case, scoring nuclear polymorphism, potentially contributes to differences in allocating overall grade and confirm the need for improved nuclear grading criteria. Now, I think criteria have been sharpened a lot, not just for breast cancer grading, but for instance, for prostate cancer and Gleason grading is redefined every so many years, but the COPPAs are not really improving anymore. So there is probably the space that the gain that we can make by having better criteria is a bit exhausted. And I think AI could be a great help to do better, to give us an aid to have more consistent scoring. Now, another reason for looking at AI is actually this one. When we defined grading, we didn't know a lot about breast cancer subtypes. And today, we all know that actually breast cancer is not one disease. It's actually, we have different subtypes which are very different in their characteristics and also in their treatment planning. So we have the luminals, which are the least aggressive ones, and then we distinguish between luminal A and luminal B. And basically, these are hormone receptor positives. So the first line of treatment would be hormonal therapy. These patients will respond typically very well to hormonal therapy. We know we have the cases that are a bit more aggressive, which are HER2 enriched. So they have an overexpression of HER2. And HER2 enriched typically benefit from HER2 targeted therapy. They have worse prognosis, but luckily we have a good therapy for that. Most aggressive ones are the ones we call triple negative, which are hormone receptor and HER2 negative. And these patients actually have the worst prognosis and unfortunately also the least treatment options. So typically for triple negative, we will probably choose chemotherapy because they are aggressive tumors, not a lot of therapy options. So chemotherapy is very much used for these cases. Now, you have to realize triple negatives are some 10 to 15% of the breast cancers. And if you look at the grading, typically triple negatives are high grade with over 60% are grade 3. Now, the reason for this is when we developed a grading system and we developed these criteria that I showed you. So how do we translate the number of mitoses into a grade? How do we translate the tumor formation into a grade? We took into account this whole spectrum of cases. And the triple negatives typically have a lot of mitosis. They have a very bad appearance. So the scoring criteria are optimized for all tumors, but actually they are not optimized, for instance, for triple negatives, which means that for triple negatives, they don't give you a lot of information because most of these cases are grade 3. Now, you can also see it very nicely here. Let's not go into a lot of detail, but here in the study, they show that actually there is a very strong relationship between hormone receptor status and the grading, the different components of the grading. So nuclear grade typically is lower in hormone receptor positives than it is in hormone receptor negatives, and the same for mitotic index. So you can imagine if you have a triple negative, then they will pretty much always score high on mitosis and nuclear grade. And sorry, this is in Dutch, but probably for the UK and many countries, this is the same. If we decide on chemotherapy for triple negatives, we don't take grading into account because all of them are high grade, or a lot of them are high grade. So grading is not used for treatment planning at all for triple negatives. Now, we do realize that this is, I think, a very interesting graph. What you can see here is it's not a very large set of cases, but what you can see here is survival curve for triple negative breast cancers for people in the orange line that only had surgery and people with the blue line that had surgery and chemotherapy. And what we can see is that if people only have surgery, 50% will be recurrence-free after 5 years. And the good thing of triple negatives is if they are recurrence-free in 5 years, actually, they do typically very well. So recurrences typically occur very early, within the first 3 to 4 years. So 50% is recurrence-free in 5 years, even despite not having chemotherapy. If you give patients chemotherapy, then you add another 16% to this. So basically it means that chemotherapy is only used for 16% of cases. Some 1/3 will still get a recurrence even despite having chemotherapy, and 50% will not have recurrence even if you don't give them chemotherapy. So only 16% will at least clearly benefit from chemotherapy, which means that we are over-treating a lot of patients. And of course, this is not so black and white. It could be that some patients will still have benefit later on. We don't know exactly what the benefit is for patients that still do get a recurrence. Maybe they do better in the future. But still, I think it's quite striking that the amount of patients that benefit from chemotherapy is actually quite limited, considering that we give chemotherapy to all these patients, to all pretty much the 100% in this group. So we feel that we might be able to redefine grading for triple-negative breast cancers in such a way that it is more prognostic and gives us better discriminatory power for these patients. So the aims of our research are, we would like to improve reproducibility of breast cancer grading. We would like to redefine grading for the different breast cancer subtypes, because I think it's very clear for everyone that grading was defined before we knew about breast cancer subtypes. There is a strong overlap between the grading and hormone receptor HER2 positivity. And we could probably do better in having a different grading scheme for the different subtypes. And we would like to use grading and make that more reproducible, but also make it more quantitative to identify patients that might benefit from either therapy escalation or de-escalation. So we want to go towards a bit more precision medicine by having a more accurate, more quantitative grading. Now, before we can do any grading, we need our computer to be able to distinguish tumor cells from other cells in the tissue. And actually, this is not as straightforward as you might think it is. I will just give you a couple of examples. This is ongoing research. But just to give you a feel for how tough it is, if you want to have an AI tell you whether a mitotic figure is actually should be counted as a mitotic tumor cell, you have to know exactly which cell is a tumor cell. So it's not just enough to have, let's say, a rough estimate of where the tumor is. You really want to be able, basically, to at a cell level to say, this is a tumor cell and the next one is not. And this is really tricky, even for a human being, even for a trained pathologist. You will not be able for every single cell to be able to say, okay, but this is a tumor cell, this is not. So we have been developing what we call tumor segmentation. And what you can see here is actually a very nice case where in yellowish color, the computer says this is tumor. In blue, this is not tumor. Now, this one is a very nice one, but sometimes we also want to distinguish, for instance, between DCIS, so non-invasive epithelium, and invasive epithelium. And here we can see where the computer makes mistakes, because it does see this is abnormal epithelium, the green. But it thinks actually that it is DCIS because it doesn't see the invasion yet. So here we're struggling, and you can see that partly it classifies this correctly as invasive, but partly it thinks it's non-invasive. This is just an example. Another one is this one, where it sees there is something going on, but it has a hard time seeing whether there is invasion or not. We are still optimizing this, and these are just a couple of examples where it struggles. Even more difficult is if you get lobular carcinomas, and this is actually a case where it works quite well. But you can imagine that finding these tiny individual tumor cells or strands of cells is really tough, also for pathologists, as I said. Right? If I point you at one cell and I say, okay, you have to decide tumor cell or non-tumor cell. Is it stroma? Is it tumor? It's not always doable. And sometimes the AI actually finds tumor cells, but also misses tumor cells, especially for lobular cases. Now, that's ongoing work, and we do quite well. I think 80 to 90% of cases are very well segmented. We still have cases that are a bit problematic. Now, if you do segmentation, then this is also ongoing work. For instance, if you look at tumor formation scoring, this is what you can do. And I can zoom in a bit. So now we can distinguish between tubular and solid growth. And here you can see in orange is where the computer thinks it's tubular growth within the tumor. And the green is where it says this is solid growth. And you can already quite easily understand now that if I do this and it works well, I can have a very accurate percentage of tubal formation in this tumor. So I don't have to go to these coarse categories of between 10% over 75%. But here I can really have my computer say this is 60%, 40% or whatever. It's very reproducible and it's very accurate. Now, this is also ongoing work. We also looked at the nuclear polymorphism scoring, which is also a tricky one, and as we have seen, is also prone to observer variability. So what we did was we did a study in which we selected 125 small regions in breast tumors. And these regions were selected by a pathologist, and they are kind of homogeneous in their nuclear polymorphism score. So they are like the region you can see on the right here. They are pretty homogeneous. And we asked 10 pathologists to score these regions as a score 1, 2, 3 for nuclear polymorphism. And to help them, and I have to see my next slide, yeah. So to help them, we gave a tumor region, and next to it, we gave, from the same slide, a healthy region, because typically pathologists look at, let's say, had the distinction between normal epithelium and tumor epithelium to make the score 1, 2, 3. So this is the user interface we use. We asked them for small regions, which is scored 1, 2, 3 for nuclear polymorphism. And then if you look at the results, this is what the results are of 10 pathologists. So every pathologist here is one row, and every region is one column. And you can see the colors are grade 1, 2, 3. Now, obviously, you would like basically every column to have one color. So you would like a specific region, all 10 pathologists, if they would all score this as a score 2, then the entire column would be yellow. And as you can very easily see, there is a lot of difference between pathologists. You see there is a lot of, pretty much every column, except for a few, has different colors in it. And these are pathologists that sign out breast cancer cases on a daily basis. So these are not just random people, not random pathologists. These are people that we expect and trust to do this reliably. So this shows how difficult this task is, I think. Now, we decided to build AI for this. And typically, if we build AI, what we do is, if we have, for instance, the data, as in this case of 10 pathologists, we typically say, okay, we want to aggregate that data into one score, and we want to train the AI on the basis of that score. So I would like to give an image to the AI and then say, okay, this image should be a 1, 2, 3. And typically what people do in this field is would say, okay, let's go for a majority vote. So if we have a case where 5 pathologists say it's a 2, then we would say, okay, the majority, of 6 maybe, we would say, okay, the majority is a 2. So let's tell the AI this image should be nuclear polymorphism score 2. But in this case, if you would do this, you would end up with something like this. You could say the left column is a majority 2. In this case, it's probably a tie, but you get the message. And the right one is also score 2. But obviously for everyone in this audience, these are not the same cases, right? One is a 2, maybe consensus 2 or majority 2, but it's on the border between 1 and 2. The right one is a 2 on the border between 2 and 3. So they are not the same 2. Actually, one is a 1.5, the other one is a 2.5. And when we realized this, we said, well, but AI is not limited to a score 1, 2, 3. So what we can do rather than take a majority vote is we can take an average vote. And we can train the AI to not output a 2 for these 2 cases, but actually we can train the AI to say the left one is a 1.5 and the right one is a 2.5. Which is a bit odd for the human and for the trained pathologist. You would say there is no 2.5, there is no 2.3 or 2.7. The AI doesn't mind, right? The AI can just be trained to output a 2.7 if, let's say, 7 out of 10 pathologists would say it's a 3 and the other 3 would say it's a 2, no problem. So we train the AI to do this. And now we can distinguish not in 3 classes, but we can distinguish in 5 or 7 or whatever classes we want to. And for instance, here you can see how the AI says the left one is close to a 1, the right one is close to a 3. And now we have intermediate steps with maybe a 1.5, a 2, a 2.5, and a 3. So the AI is capable of really being more fine-grained here. Now, we did a study in which we tested the AI, and now we asked the AI to do a quantitative scoring, but bring it back to the 3 classes. And we compared the AI on whole slide image level. So we asked 3 pathologists to score 118 cases, and we compared their outputs. We compared the pathologists among each other, and we compared to the AI as well. And actually what we found was that the kappa values of one pathologist were highest, but actually, one of the pathologists was highest, but actually AI ranked second in, let's say, performing this task. So AI did as good as the pathologist in this task. And the great thing here now is that we can process a slide and actually we can have it make this kind of heat maps where we say there is a component that is kind of 1 score in this region. There is a component that's kind of a 2 score in this region, and there's a component that's a 3 score in this region. And we have all the values in between. So here we can go way beyond just having a 1 score for the entire slide, which is a 1, 2, 3, but you could get way more quantitative data here. Okay, the third component of grading that we studied is mitosis counting. Actually, this one we studied most extensively. And we did some studies in the past where we showed that AI can find mitosis and can be very comparable to pathologists. So we did a study with a couple of pathologists, and we found if we compare a few pathologists, we can compare with the AI. AI is actually quite well capable of doing this. Now, with our spin-off company, Eosin, we did a follow-up study in which we asked pathologists to use AI. So we studied for 100 cases. We had a panel of 28 pathologists, and every pathologist scored 100 cases with and without the aid of AI. So this is not about AI versus human. This is pathologists without AI versus pathologists with AI. And the user interface looks something like this. So the AI processes the image and it shows you small green pluses where it finds mitosis. So you can use this overview to select the hotspot, because as a pathologist, you count mitosis in the hotspot. And next, if you zoom in, the AI will show you small squares indicating the individual mitotic figures. So the AI helps you to find the region to count, and it helps you to do the actual counting. We use this for IVDR certification, and we asked, as I said, 20 pathologists from all over the world, ranging from Australia to the US to UK, Brazil. And we have people with little experience, only 1 to 5 years, and people with a lot of experience, over 15 years. And we did the study, and results are actually quite interesting. So we scored 3 components. First one, maybe on the left, is efficiency. We timed how much time it took them to do this mitosis counting. And to be honest, I was a bit disappointing. We found that they have a significant time gain, but the time gain is only 10%, which is not a lot. I think in practice, this will be much and much higher. I think because it was a study setting, because people were not really used to using this kind of technology, I think we underestimate the time gain. I think if you are very well used to it, you're used to having this in your workflow, very nicely integrated, I think you should be able to go up to 50% or even more time gain. Now, the second thing we studied was accuracy. And accuracy in this case, we tried to have kind of a reference standard by having 3 pathologists score these cases, which are very expert pathologists, so they had a lot of experience. And actually what we found was even these expert pathologists didn't have very great kappa values. So we found that our, let's say, hard ground truth reference was not as solid as we hoped it was. So even, let's say, the top performing pathologists are not really that good in scoring mitosis. There is still a degree of variability. So if we compare the 28 pathologists in our study to the expert pathologists, what we found was we did non-inferiority testing. We found AI does not make them inferior to without AI, but they also don't improve on accuracy, which I think is part of the fact that our reference standard is just not solid enough. Now, I think the most important thing here is that the consistency between the pathologists goes from a cap of 0.33 to a cap of 0.48, which means, and this is highly significant, which means that actually pathologists get way more consistent in scoring. And just to give you 2 examples, on the left here you can see an example where these are the regions that pathologists select to do the counting in. So these are the hotspots they select on the left without AI and on the right with AI. And on the top you can see in our example the exact same thing. And what you can see is that because of these tiny green dots, actually the consistency of picking the hotspot goes up considerably. And we did a test and we see this as a significant effect. So pathologists, because they have this overview of where are the mitoses, they tend to go to much more homogeneous regions. And you can see on the right is even more striking. You can see on the left, without AI, pathologists tend to favor different areas to do the counting. because of the AI, they really go to much more homogeneous area selection, which also is reflected in the mitotic counts. I think this is a very nice example of how AI can help you to be much more consistent in your scoring, and as such, also help you to get a more consistent grading. Now, as I said in the beginning, we want to see if we can redefine, and maybe that's a bit high bar, but we want to see if we can at least study and provide evidence of grading criteria which are tuned for different breast cancer subtypes. So we did a study in which we have 1,600 hormone receptor positives, and we looked at if we just subdivide them in mitosis low, mitosis high. We look at the hazard ratio for different cutoffs. So we just take mitotic count by AI, 1,600 cases. So this is a study that is really hard to do with humans. Mitosis counting, not just saying a score 1 to 3, but really counting every single mitosis in the hotspot. 1,600 cases in a very consistent manner is a very tough study. But with AI, this is very doable. So we had AI count mitosis in the hotspot. And then we see what happens to the hazard ratio of Cox regression model if we cut off at 5, 6, 7, 8, 9, 10, etc. mitotic figures. And here we found that in this set of cases, the optimal cutoff is actually at 9, which is different, slightly different from what we do today. So this is a study, I'm not saying we should use 9 today, but this is a study that shows you how we can use AI on large cohorts to redefine and provide evidence of grading. And do this in large-scale studies, where in this case we can say, okay, we focus on hormone receptor positives, or we focus on triple negatives. So we can redefine, we can study again the criteria that we want to apply for grading. And here we find if we take this cutoff of 9, then if you look at this survival curve, you can see actually that log rank test gives you very strongly significant measure. Now, we did a study with Mayo Clinics in which we studied, I showed you before this graph, we studied, can we use AI to find prognostic information on triple negatives? And we collected a set of cases, which is comparable to what I showed you before, the orange line. So we have, and I forgot the numbers, I think some 400 or 500 cases of triple negatives that are not treated by chemotherapy. So they only had surgery. And we study the prognostic value of mitosis. And we found actually that there is a significant value in counting mitosis in this subgroup. So the orange line here, these are different patients, but the orange line here can be subdivided on the basis of mitotic count into 3 lines. In this case, mitotic density low, mitotic density high, and something in between. And this is not mitotic density scored as I showed you the way pathologists do it, because then all of them would be high. In this case, we just redefined the thresholds that we took. And with different thresholds, you can see that actually there is a lot of prognostic value in mitotic counting. Now, the same group at Mayo did a similar study with tumor-infiltrating lymphocytes, and they found actually similar results. If you look at TILs, then also this group of patients, triple negatives without chemotherapy, can be subdivided into groups with different risk models, different risk prediction. So we are now doing a big study in which we try to combine mitotic count as a quantitative measure, but also nucleopolymorphism, tumor formation, and TILs. And we want to see if we can combine all of these as, let's say, quantitative measures, objectively scored by AI, into a risk model that can help us to distinguish maybe a subgroup of triple negatives that has very good baseline prognosis and could forego chemotherapy. And we have done similar work on trying to predict the response to neoadjuvant chemotherapy. And in this study, it's also not very large scale yet, I think. We also found that if we take biopsies, pre-treatment biopsies, we can use AI to automate TILs and mitosis. And also here we can find prognostic information that can, or in this case, predictive information that can help us to predict whether a patient will respond to chemotherapy. And we can decide whether we want to give neoadjuvant chemotherapy or maybe go for surgery or some other treatment form right away. Now, because of the sake of time, I will skip the next example. Okay, this I would very briefly like to mention. What we see happen now is, and this is a company from Sweden, I'm not involved in any way in this, Stratipath, that has the same goal as what I just explained to you. So it's AI that takes an H&E section, scanned H&E section, and gives a risk score. In this case, it's not, as I showed you, based on grading. This is a risk score that's really, let's say, AI-based, black box kind of risk score, which is a different approach to the same thing. It's kind of comparable. And what we see happen on the market now is that actually more and more of these, let's say, morphology-based, HLA-based products come to the market, which is an interesting phenomenon, right? Because it could be at some point that this even gets next to the pathologist. So you, as a pathologist, you do the grading, but you can also have a Stratipath risk score like we have Oncotype DX or MammaPrint, right? This is a bit comparable, I think, development. This risk score was studied a lot for hormone receptor positive, HER2 negative patients. And they found actually that it gives independent prognostic information with an HR of 2.76 on these cases in a kind of a large cohort of 2,700 patients. That's a very interesting development, I think. Okay, I will skip this example because it's not breast cancer, and I think my time is up. I would like to go to show you my research group, which is a great large group. So we have a group of close to 40 people, which are all fully embedded in the pathology department, and we completely focus on pathology projects. And so if you have an interest in collaborating with us, please let me know. We always love to work with pathologists. We have a lot of pathologists in our research, and we need even more because I think without pathologists, we can't develop AI. And these are the people that fund our research, which obviously is also very important. And I always like this slide to close. This is how I often feel being still a young boy, and I'm sitting on top of the repertoire of AI techniques that is developing. And I think we have a bright future in which we can have, help pathologists to do the best job for the patient by giving them the proper AI tools. Okay.
Thank you very much, Jeroen. That was an absolutely fantastic lecture. And we've already got some questions in the Q&A box. So I'll start off with a couple of those, if you don't mind, and just encourage people in the meantime to ask questions. So we've got an anonymous attendee who says, "Great lecture, thank you. Do you know what nuclear features or histological features the module used to assign nuclear grade? Are you able to comment on the explainability of the results?"
That's a good question. Explainability is always a tricky one. And in this case, we have not studied that in detail. So there are techniques to, let's say, to do some explainability. Typically, they're not very strong. So that's one of the drawbacks of this kind of approach, right? We trained it. We can validate it on region level, on slide level, but we are not capable at this point to explain what it is looking at. So I guess the question is no, but in this case, I would imagine it's very comparable to what you do as a pathologist, because
Right.
we trained it on small regions with a pathologist score, which was based on humans. So it must be features that are very close to what you look as a human.
Great, thank you. So Mark Ahrens, who's the General Secretary of PathSoc, he says, "Very interesting talk, thank you. Have you considered correlating DNA molecular changes or transcriptomic data from these cohorts of breast cancers with their overall grade, tubular grade, nuclear pleomorphism grade, and mitotic counts and TILs, etc.?
Yeah, great question. I think it's definitely worthwhile. So what we are doing now in our studies is we are collecting large cohorts, and we try to collect also molecular data as much as we can. So transcriptomics, for instance. And then we want to see, but I don't have any data on that yet, how these correlate. Because I think there are studies that show already that, for instance, Oncotype DX kind of tests can be how you can do, let's say, H&E-based AI technologies that give scores that are very similar to those. We haven't done it yet, but it's definitely on our radar to do it. It does mean that we need large cohorts, and we need large cohorts with outcome data, but also molecular data. And those are not always easy to get, of course. So I spent a lot of my time on actually getting access to nice cohorts. So this is also a shout out for people. If you have good data, then yeah, it's very welcome, because we love to test our AI techniques. But I think it's good, and probably it could be that in the end we find that we can do some kind of image-based biomarker, which is complementary to some molecular tests, right? You might want to combine them in the future. I think the good thing is that the AI-based test, it can be much cheaper than some very expensive oncotype kind of tests, because basically we only need an HD slide and a computer. So it could be much cheaper than a very expensive test, which would also make it available for maybe regions that cannot afford to do the molecular testing.
Yeah, that's great. Well, I've got a couple of questions, if you don't mind.
Sure, please.
They're not up in the chat box, so you can't see them, I'm afraid. But I guess the mitosis counting algorithm that you've developed, that's been based obviously on breast cancers. How generalizable is that algorithm onto other cancer types? Be they carcinomas or even tumors of other cell origin?
That's a great question, and it's one that I get a lot. Actually, the bad news is it is not very, let's say, translatable. What we often see is that if we develop an algorithm for some application and you use it for something that is slightly different, you typically get a lot of false positives. And for instance, this algorithm, we tried it on, I think, melanoma cases. What you typically find is that it will find your mitosis because they are kind of similar. But typically, you have cells, and I'm not sure what that was in melanoma, but you have some cells that the algorithm during training just didn't see in breast cancer, which if it finds them in, for instance, melanoma, it just doesn't know what it is, right? It has not been seeing these cells. So if it then suddenly sees something that it hasn't seen during training, it has to make a decision. Is this a mitosis or not? And in that case, you typically get a lot of false positives. So for instance, for the lymph nodes, what we have seen is that apparently in our training cases, there were not a lot of blood vessels. So then if it happens to see a blood vessel in a lymph node, if you process that with your algorithm, it typically will flag it and say, hey, look, this is a metastasis. It's not metastasis, but the algorithm just doesn't see it during training. And you can imagine also for a beginning pathologist, I think, if you encounter something that you haven't been pointed out at, you just have no clue, right? It's just, you have to make a random guess what it is.
Yeah.
So I think you can take, in this case, the breast cancer mitosis algorithm as a starting point, but you will have to run it on melanoma cases and do more annotations or refine the algorithm to really make it tuned for that area. That's also the reason why if you certify an algorithm, you typically had the notified bodies want you to certify it for a very narrow range of applications. So you certify it for mitosis and breast cancer. You're not, it's really tough to have an algorithm that says, okay, mitotic detection in cancer overall. Because to prove that it works is extremely difficult. And typically you see the range of applications is very narrow.
Yeah. No, that's great. So perhaps on the back of that, and I know that a question is coming in the meantime, could you design an algorithm on the basis of, for example, instead of mitotic figures, immunohistochemical stains, which are highlighting features of mitosis? So there's the SIR10 stain, which it doesn't stain the whole cell cycle, but it highlights particular phases of the cell cycle which is associated with mitosis. Is that one way of counteracting, perhaps coming up with a compromise in melanomas with all of the pigment?
Yeah, sure. I didn't show any details today, but actually the way we trained our mitosis algorithm. So the mitosis algorithm works on HND slides. But what we did was we took HND slides, we scanned them. Then we took off the cover glass and we restained them with immunohistochemistry for, in our case, phosphorylated histone H3, so PHH3.
Yeah, I think it's the
which
same.
is not a perfect marker, but it's actually quite a good marker.
Mm.
Then we scanned the exact same slide again, and we overlaid the two. And so our reference is not based on humans, but actually our reference is based on immunohistochemistry. Which is cool because it helps you on one hand, it avoids the tedious work for the pathologists.
Mm-hmm.
We took triple negative breast cancers for this, and there are like 10,000 mitotic figures in one breast cancer. So rather than having 5 pathologists click 10,000 mitoses, which is not going to happen, and is also not completely objective, we had 10,000 mitotic figures, which are a bit noisy because your immune marker is not perfect.
Yeah.
But it's much and much better and scales up much easier than having manual annotations. So we used immunohistochemistry. We did the same thing for inflammatory cells in kidney biopsies. So rather than having a pathologist click, which is actually also quite subjective, right? Sometimes you don't know the difference between lymphocyte and epithelial cell. We just said, okay, we restain and we do CD3, CD20 cocktail, I think, and overlay the images and take the immunohistochemistry as a reference. So it takes a bit more work on the lab, but you have a very strong reference standard. So this is something we do quite often. If there's a good immunohistochemical marker, we try to use that approach.
Okay, that's terrific. Okay, so a question from Adoki Kasimu, who says, great lecture. How do your findings get integrated into pathology reporting?
That's a good question. And to be honest, we are not that far yet. So we are developing the AI, we are validating AI. In our own lab, we started to use the lymph node algorithm in clinical practice. And what we will do and what we have to do according to IVDR, so the pathologist will use the AI as a guide, and we have to be very clear on that. So, for instance, our website has to also show that we use AI in our diagnostic process. And the report will have a standard line saying pathologist was aided by AI version this and that, algorithm this and that.
Mm-hmm.
So for clarity and to be completely transparent, we provide information in the report that AI was used on a specific case. But in this case, because the pathologist uses the AI as a guide, so the AI shows, okay, these could be metastases in these lymph nodes. But obviously, in the end, it's the pathologist's responsibility to sign out the case. But we did validate the AI, and we are very transparent in reporting that we are using AI.
Great, thank you. Then another question, Deepika Vunam, who says, great lecture, thank you. How do we contact you with respect to collaborations? Would you have an email address or a particular contact person that they can reach out to?
I have an email address. I'm not sure I can say it out loud now, but I'm sure if that's very helpful. You should be able to find it. I'm quite present in LinkedIn.
Yeah, perhaps we can also circulate it afterwards. So I just have one last question, if I'm allowed. You showed ProActing and also the StratiPath breast cancer risk score. And you sort of mentioned also regulation at the end in terms of IVDR. Are there any sort of studies looking at the different risk scores and which ones perhaps are the most precise, so that going forward, when introducing these new techniques into clinical practice, we know which ones are the most robust?
Yeah, great question. To be honest, Sarah, I think we are still in the phase where we are developing things. I think we should at some point start to do clinical trials, right? And really start to incorporate these scores. I think actually StratiPath is maybe doing that, I'm not sure. I know, for instance, in the Netherlands, in Amsterdam, they are doing a study now, clinical trial, where they de-escalate chemotherapy for triple negatives on the basis of TILs. So I think at some point we have to start doing these studies and also see how different scores correlate. I don't think there is a lot of information on that yet. And probably it's still too early for that, right? I think there's a lot of promise. I think there's a lot of hype on AI in pathology to be honest, I feel there is still too much hype. I think there are a lot of studies that compare some AI to some pathologists, and they see they can do well, and then they say, okay, look, this is the future of pathology. I don't think life is that simple. And I think the value of AI in pathology still has to be proven. I think a lot of it is a bit overhyped. And I think we have to start doing very well developed studies using AI in clinical practice to really see the added value. I'm quite confident that we can do some risk prediction on what I showed you today. But how good it is, how it will correlate with other studies, with other biomarkers, we just have to see. And I hope the next 5 to 10 years will give us a lot more evidence here to, yeah, maybe in 5 years I can give you the answer. I would love to.
Okay, well, thank you very, very much. And I know we're now a tiny bit over time. I'd like to really thank you very, very much for an excellent lecture. Really inspiring, as inspiring as the first lecture I saw in the US many years ago. So thank you very much, and thank you all for attending. And just to highlight that our next Grand Round lecture is in May, and it's May 14th, as you can see here on the screen, and this is going to be given by Professor Mariam Jamal Hanjani, who will be speaking about the value of research autopsies in a variety of different diseases, and also how they have how you can use these to demonstrate the evolution of tumors during the clinical course. So I'd like to thank you all very much for attending, and thank you again to Professor van der Laak for giving such a fantastic lecture. And with that, I'll close the session. Thank you.